The patient on table 3 has been open for 11 minutes. Not because of complications, because the chief surgeon threw a retractor across the room and told the attending to get out of his theater. The attending, 14 years of cardiothoracic surgery, 2,400 procedures, is standing in the hallway in his gown, still sterile, listening to the monitors through a closed door. Inside, Gordon Ramsay is finishing the bypass alone. No one in this building has ever seen anything like it. No one in this building has had their complication rate drop 40% in 6 days either. 48 hours earlier, nobody knew his name was on the staff directory. St. Augustine Medical Center processes 1,200 patients a week, 11 operating theaters, a cardiac unit ranked 34th in the country, which sounds impressive until you understand that 33 hospitals are doing it better. Mortality rate on complex bypass procedures, 3.1%. The national benchmark is 2.4%. The gap is small in percentage terms. In a hospital this size, it is 11 people a year. The board knew. They hired him anyway. They hired who they thought he was, a celebrity with a medical degree from Edinburgh, board-certified in general surgery, fellowship-trained in cardiac, who had spent 4 years running a consulting firm with one specialty, institutions that had stopped being afraid of being mediocre. Restaurants, logistics companies, once a shipping port in Rotterdam. Always the same diagnosis, always the same resistance, always the same result. His first morning, he arrives at 5:47 a.m. No introduction, no welcome meeting. He walks the ward, picks up 3 patient charts, reads them standing at the nurse's station, sets them down, and says 4 words to no one in particular. This place is broken. Nobody argues. Somewhere in the pre-op bay, a nurse named Claire, 19 years at St. Augustine, thinks, finally. And she doesn't know yet what she is saying yes to, but something in the building exhales. Pay attention to that. It matters later. The ones who are already good are about to get better. The ones who have been coasting, that is a different story, and it arrives in about 3 minutes. By 7:15, the surgical team for the day's first case is assembled in Theater 2. Triple bypass, 58-year-old male, high risk, elective, 2 previous cardiac events. Ramsay walks in, looks at the instrument tray, stops. Who laid this out? The scrub tech raises her hand. Imara, 98th percentile on her certification board, 11 years in surgical theaters. He doesn't raise his voice. That is the first surprise. The whole room expects the voice, and it doesn't come. He picks up the primary scalpel, holds it to the overhead light, sets it down with the specific care of someone who is restraining something. This blade has been autoclaved 12 times. You can feel the edge degrading at the tip. He looks at her, not with anger, with something more unsettling. Absolute seriousness. You laid a compromised blade on my tray and you walked away from it. He tells her to replace every blade, tells her to explain aloud to the room why she didn't catch it. She replaces the blades without a word. Weeks later, she will say it was the most focused she had ever been in that theater. That is the thing about a genuine standard. It lifts the people who are already good. It finds what they are capable of and refuses to accept anything less. The scrub tech who almost handed a compromised scalpel into a man's open chest will never make that error again. Not because she was humiliated, because she was held to what she actually knew. The bypass begins at 8:03. Ramsay operates the way he apparently does everything, with the settled refusal to accept that the current method is optimal. He narrates every move aloud, not for teaching, for accountability. Every incision called, every decision announced before it is made. The anesthesiologist, 6,000 procedures, 2 departmental commendations, has never had a surgeon narrate a bypass like a live record. Proximal anastomosis. I want flow confirmed before we close, not assumed, confirmed. The residents in the observation gallery above are typing faster than they have ever typed in a clinical setting. They are not writing notes. They are trying to keep up. At 9:11, he pauses mid-suture. What's the patient's potassium? 3.4. When was the last reading? 40 minutes ago. Take another one now. The result? 3.1, trending down during bypass, a known risk factor for cardiac arrhythmia on reperfusion. Standard protocol flags at 3.0. He addresses it at 3.1. 3.0 is when you react, he tells the room. 3.1 is when you think. The residents stop typing. That one goes in memory, not notes. But the line isn't the story. At 9:34, something on a secondary chart, clipped to the back of the case file, unrelated to his patient, catches his eye. He stops the procedure. Not a pause, a stop. Instruments handed off, hands raised, a full step back from the table. He looks at the circulating nurse. Pull the chart for bed 14, cardiac ward. She doesn't move immediately. You don't stop a bypass for a chart pull. That is not a thing that happens in a surgical theater. Now. The chart arrives. He reads it in 40 seconds. Then he picks up the internal phone and tells the cardiac ward nurse with perfect unnerving calm to hold the 10 a.m. medication administration for bed 14 until pharmacy reviews the digitalis order. The reason, the dose in the system reads 0.25 milligrams. The patient weighs 52 kilograms. The dose is calibrated for a 70-kilogram adult. It passed through 2 independent pharmacist checks. The patient's own cardiologist signed off on it 3 days ago and reviewed it once since. By a margin that has a specific name in a coroner's report, it is a potentially fatal dose. Ramsay found it on a chart he was never assigned for a patient he has never met in the middle of an open chest bypass because he reads everything in front of him. He steps back to the table. Where were we? The theater goes quiet. Not the quiet of confusion, the specific quiet of people recalibrating exactly who they're standing next to. By day 3, the hospital is divided. Not about whether he's effective, about whether effectiveness delivered this way is something an institution can survive. The attending he removed from Theater 2 has filed a formal complaint with the surgical board. The nursing union has submitted a workplace conduct grievance. The board is fielding calls from the insurance carrier about verbal conduct liability, and the cardiac unit's complication rate for the week is 1.1%. Nobody in the boardroom wants to say what that number means out loud. What it means is that the man they are preparing to sanction just ran the safest cardiac week this hospital has recorded in 4 years. Here is what the boardroom is not discussing. A landmark study out of Johns Hopkins found that medical error is the 3rd leading cause of death in the United States. Not disease, not equipment failure, error. An estimated 250,000 lives a year. Systemic, preventable, and tolerated so quietly that it never appears in the CDC's official list of causes of death because hospitals are not required to record it that way.
And here is what the formal complaint filed against Ramsay does not mention. The attending surgeon removed from Theater 2 carried a 4.7% post-operative infection rate on his ward over the last 90 days. The accepted industry benchmark is 2%. Nobody filed a grievance about that. Nobody called a board meeting. Nobody said, this is the number. This is what it costs. These are the people. So the question this hospital is now sitting with, and the question forming in you right now, is whether Gordon Ramsay is the problem, or whether he is the diagnosis. This is what happens when you follow a premise all the way to where it actually leads. You come in expecting spectacular chaos, a scalpel thrown into a wall, a nurse reduced to tears over a saline bag, the show. What you find instead is an institution discovering it has been too small for its patients for a very long time, and that the man tearing it apart is doing so with the same logic every time. Not good enough is not neutral. Not good enough costs something. Someone pays for it, and it is never the institution. The kitchens Ramsay walks into are not broken because the chefs are bad people. They are broken because the cost of confronting mediocrity every day is high, visible, and exhausting, and the cost of tolerating it is invisible, diffused, and someone else's problem to name. Hospitals fail the same way restaurants do, not through catastrophe, through the slow, daily accumulation of acceptable. That is what lives underneath the premise. That was already there before he arrived. The patient on table 3. The bypass closes clean. Reperfusion without arrhythmia. Potassium at 3.4 and climbing. The attending is called back in for closure because Ramsay is not interested in punishment. He's interested in the work, and the work requires the best person for each stage of it. Ramsay strips his gloves in the scrub room and doesn't debrief. The residents wait. He doesn't speak. In the hallway, the attending is still there. Ramsay stops, looks at him for a long moment, the kind of moment that is its own sentence. "You're a good surgeon," he says. "You've just been allowed to be an average one." He walks to the elevator. In bed 14, a patient who does not know how close the 10 a.m. round came to being his last is asking a nurse when his lunch is arriving. She tells him soon. The medication chart has already been corrected. No one told him.